Welcome to ATCM, the Men's Medicine channel. 50-year-old male patient came to emergency department complaining of acute onset of aphasia since 2 hours with patient noticed right upper limb and lower limb weakness. On arrival to ER, on tissue density assessment, patient was conscious and oriented. On going to primary survey, on airway appears patent, there is no gurgling or no any secretions. Coming to breathing part, air and bilateral equal with respiratory rate is 20 breaths per minute. Saturation is 98% in room air. Coming to circulation, BP is 160/80 and pulse rate is 80 per minute. Coming to disability, GCS is E for V is for V aphasia, VA, and MS. And PP is 2.5 millimeters and patient moving on 4 limbs with power examination. Right side is upper limb lower 4/5 is the power, left side is 5/5. And expression heart temperature is normal and GRS is 140. So patient went to ER with acute onset of aphasia 2 hours with the right side weakness.
Always better to tell what type of aphasia. Sensory aphasia, connective aphasia, dysarthria. What is the type of
Patient global aphasia.
global aphasia? Global aphasia means
Patient is not able to sensory motor is
patient is not able to comprehend. Whatever he sees, patient is not listening, obeying. That is sensory aphasia. Patient is not talking. Both are there or only not able to talk? Both are different. See, both are different and both are in different areas. That's why I'm telling. Motor means it is locus area. Other one is sensory area. Area numbers are different. Okay, depending on the straw. Sometimes depending on the blood vessel, it may be different.
Patient is understanding what we are telling.
So that is sensory part is normal.
Motor phase.
But patient is not able to talk. He know what to talk, but he is not able to talk. That's a Broca's aphasia. Sorry, Broca's area, motor aphasia.
So patient enrolled in ER with since 2 hours of onset of symptoms like global motor aphasia and right side weakness. So we taken a CT brain to rule out any hemorrhagic or any acute infarct. So in CT brain we taken showing left side MCA tertiary infarct with hemorrhagic transformation. So patient is not a candidate for thrombolysis.
Why is not a candidate for thrombolysis, or what are the contraindication for thrombolysis in emergency?
In emergency department, thrombolysis contraindication one is hemorrhagic transformation or any intracerebral bleed, or any major surgery done in within 3 months, or any upper GI bleed of 25 days history. Then patient on any oral anticoagulants with INR is more than 1.7. Then platelet is less than 1 lakh. BP is more than 185/105. Age is less than 18 years and age is more than 80 years. Contraindication for thrombolysis. So this patient is not a candidate for thrombolysis. So our other management is like patient with intracranial bleed. So secondary brain damage is to prevent this next plan. So adjunct to primary survey, we take an ECG to rule out any.
When there is bleed, what are the other things you look into? Look for the patient. Like you are telling there is a bleed. What are the other things immediately you document? You know that there is a bleed. What are the other things immediately you check? BP, pupils.
BP, pupils, saturation, heart rate.
You have to look for any other brain edema features, scoring features. All these things you have to document it. We know that it is not there, and since it is not there, you are not telling. But if you don't document all these things, afterwards this can become a problem. You have to clearly document there is no signs of raised intracranial tension, or there is no false localizing signs of ICP. That has to be.
So features of ICP like Cushing's triad, we can rule out like bradycardia with hypertension with abnormal respiratory pattern like bradypnea. These features are not there because it is already 80 and BP is 160. So our target BP in intracranial hemorrhage to keep between 140 to 160. If the BP is more than 160, we can give injection labetalol, beta blockers. Like labetalol is a drug of choice to control the BP between 140 to 160 and more than 100 to maintain the perfusion in the brain.
What are the conditions you prefer labetalol over other drugs?
Emergency,
You may not prefer labetalol.
Uh,
Emergency.
emergency, labetalol is drug of choice in intracranial bleed, in aortic section, aortic aneurysms, bleed, control heart rate. In labetalol is contraindicated or not used in patient with cardiac failure features, hypertension like pulmonary edema. In this drug of choice is NTG.
Severe cardiac failure you may avoid.
Okay. Because of beta blocker option also.
Okay.
Person the cardiac failure.
Any other condition you avoid or with caution you use? Any other condition beta blockers are not first line choice? Any hypertensive emergencies where beta blockers are not first line choice? It has to be given, but it is not first line. What is the condition? Asthmatic patient, okay, but labetalol as such will not produce any asthma aggravation, but even then asthmatic condition you try to avoid. Pheochromocytoma?
But it is
It
both
has got-
alpha and
it has got
beta action.
alpha action, but
First
ideally
is
it is a
given
beta
as-
blocker and it has got some alpha action.
Because
So always preferable drug is alpha
First is
blocker,
alpha, then
alpha
beta.
blocker, then beta blocker. Since this has got an alpha, additional alpha blockage activity, this will be better beta blocker than other beta blockers. So this is one condition where you use with caution or you always use with alpha blocker. Okay.
So first of all, we will make the position as head and is elevated to around 30 degree to avoid the necklines. Then next is to if the GCS is less than 8 or equal to 8 to patent there we will go on with the intubation. Then next to control the saturation is more than 95 with BPs between 140 to 160, MAP more than 75. Then in temperature part we will keep a normothermia, then a normal glycemia.
So temperature, sugar, BP.
PCO2 level between 35 to 45.
Okay. Sodium.
Sodium more than 145 to 155. If patient had this bleed with cerebral edema, to give hypertonic saline like 3% start, then our aim to make the sodium between 145 to 155 or raise the serum osmolality more than 300.
Okay. But BP is very high. Is it okay to increase sodium like this?
In salt dependent hypertensive patient,
So sometimes it can produce some minor effects. BP can increase, but normally because of this BP will never increase. Anyway, you are giving a drug to control the BP, and this alone, high salt intake or salt IV alone will not produce BP so much high. If there is a cardiac failure or something like that, you have to be very careful.
then
But that is not. This is not a must. You have better options. Sometimes you can give mannitol. You can put the patient on ventilator, hyperventilation. All these things are there.
short-term.
These are all short-term measures.
Then if a patient develop GCSE, initial GCSE, C4, VFAC and M6, if there is any monitor the GCS and BP hourly. So any fall in GCS or any developing any increased ICS features like vomiting, anechoria, bradycardia, hypertension, bradypnea, we will think of any risk of bleeding and repeat CT imaging, and we can give injection mannitol, which is doses 1 gram per kg. Bolus dose we can give. Then short time hyperventilation.
How do you give mannitol?
1 gram per kg.
No, how do you give?
Mannitol available is 20% 100 ml, so that is 20 gram. So 1 gram per kg is around 60 kg, 3 bottles needed.
Nearly 3 bottles you have to give.
Within 1 hour, IV bottle.
So it has to be given. Each bottle should be given less than 15 minutes. It has to be a rapid push. Otherwise, it will not work. If you give slowly, what will happen?
Osmotic diuretic action.
Only it will become a diuretic. That is the thing. Most of the time in wards you can see mannitol is given as a slow infusion. It will not give any effect. Okay. If you want to give a good effect on brain, you have to give rapid push.
Then in that patient also we can give short-term hyperventilation because hyperventilation causes PCO2 washout. So it will causes.
For that, you have to mechanically ventilate the
Ventilate the
patient.
patient,
That
yeah.
difficulty is that for intubation and all, lot of difficulties will be there. You have to do it properly. Otherwise, that itself can raise the intracranial tension.
These have been prophylactic anti-seizure medication according to new guidelines. If there is seizure, in the history of seizures, there better to start on anti-seizure medication. If there is no seizure, starting off anti-seizure medication is a school.
May not be like.
It also increase the good prognosis in mortality. There is no affecting any mortality.
If there is a seizure, definitely you have to give.
Yes.
Otherwise, a massive bleed or this is posterior cranial. So the seizure activities are very less there. But if it is in the MCA territory, large bleed, then better to give. Okay, but as per guidelines, it is not required.
Then other things are the complications. If the patient is developing dysphagia, better to get on nasal NG tubes to feeding and advise him to train the swallow. Then in newer studies, they are telling like if patient is difficulty in dysphagia, better to add on ceftriaxone 2 gram IV stat, or patient is intubating first, prophylactically add on ceftriaxone 2 gram to prevent the aspiration pneumonia or ventilator associated pneumonia. Then reversal of the anticoagulant agents. If the patient on warfarin, we can get on FFP, prothrombin rich complex, concentrated complex, or vitamin K. Patient on dabigatran, we can start on dexamab. Patient on apixaban, we can give antinextinate alpha, and heparin, we can start on proton sulfate. So patient on anticoagulants, we will reverse the INR if it is more than 1.4. Then complications like
You have started labetalol for this patient. How do you continue with the antihypertensive medication? These are the things we are going to really address in this patient.
Yeah.
So you have started labetalol in this patient. How do you continue the antihypertensive medication in your ICU?
First of all, we get control with IV medication to.
That is a short term.
Then after that, we can. In this patient, he is a known case of CAD with diabetic hypertension. CAD is there, then better to start on beta blockers.
So what beta blocker we will prefer in this? Labetalol IV is given. Okay.
Metoprolol.
Metoprolol. What is the dose?
25 mg or
25 mg.
25 mg if you are giving central release OD we can give, otherwise you have to give BD dose.
BD or TID.
TID.
Actually metoprolol acts
8
only
hours.
for 6 to 8 hours. So if you want to give a continuous 24-hour control, you have to give at least minimum 3 times. Normally it has to be given 4 times. Minimum you have to give 3 times. Okay. Otherwise you have to go for extended release metoprolol. So that can be tried. But one drug alone may not be sufficient in this type of patients. What will be the second line choice, third line choice?
calcium channel blockers, AR inhibitors, using diuretics.
Hydrolysis. In hypertensive emergencies or urgencies, one of the best drug is hydrolysis. Okay, because it has got very minimal adverse effects or contraindication compared to all other drugs. Okay, routine practice we don't use hydrolysin. Previously, hydrolysin was the second choice when it was available as IV. Now we don't get any IV hydrolysin in India, so we don't use it. But hydrolysin tablets are available, so you can safely give hydrolysin 25 milligram tablets TID or BD along with beta blockers. There is no adverse effects for major adverse effects. Okay, AC inhibitor you have to check the creatinine, potassium, so many things you have to see. Calcium channel blockers are really safe. Okay. So you should know about all these drugs because these were the drugs initially used for all hypertensive emergencies. Now, since we are not getting IV hydrolysin, we are not using it. Hydrolysin is what type of drug? So they are just vasodilators, so there are no major side effects for these drugs. Okay. What is the side effect of beta blocker in this patient? You know about the patient. What are the side effects can happen, and how do you advise the patient? Beta blocker is a good drug in this patient because cardiac disease is
CAD.
so it's a very good drug. But what is the other problem in this patient is having? What is the other diagnosis you already
No,
told?
acute seat factor with
No, other comorbidity.
diabetic. Okay. Beta blocker, if we give diabetic patient with the hypoglycemic symptoms, it will be masked by the beta blocker.
Okay, so you have to advise the patient that patient can develop hypoglycemia without his notice. So patient has to be very careful, or bystander has to be very careful. So beta blockers are very good choice since there is a coronary artery disease, but at the same time you have to warn the patient that he can develop hypoglycemia without any warning symptoms. Okay. What happened to the patient afterwards?
Patient then we admitted this patient after 2 days. We given a PMR consultation for aphasia and for gait training and for dysphagia. After that, he was trained and he's being able to speak 3 to 4 words in repetition.
Okay.
And his discharge immunity stable. With
What are the drugs you advise on discharge other than your BP control? Should we give statins?
statins? Will start.
Should we give?
Then 1 dose of oral anticoagulants also we can start, like aspirin we can start.
Okay.
Diabetic control, diabetic medication, OHS we can start.
Which are insulin? What is your opinion about this?
Each patient's insulin will be better choice.
So once the patient develops a target organ damage, including stroke, myocardial infarction, retinopathy, renal failure, insulin will be always better than OHS. OHS may control the blood sugar. Long-term benefit is only with insulin. So you should try for insulin. If the patient is not willing, only we should try for OHS. Okay. So that can be tried. Anything else? Anything else you want to add? Okay.